Good morning, everyone. I'd like to welcome you to our PICU Liberation session. Over the next 2 hours, we hope to present you with an evidence-based approach to enhancing the standard of care that we provide to critically ill children all over the world. We have gathered together a cast of characters that I think are second to none. I am blessed to have with me Christina Betters, Karen Chung, Sapna Kujadkar, Debbie Long, Brenda Morrow, and the ever-famous Jerry Zimmerman. We span from all over the world, actually. I couldn't fit the whole world on this slide, so I just gave you a little picture here. And I'm going to very quickly run through with you what we're going to be talking about for the next 2 hours. With respect to disclosures, there are some research funding for some of the speakers. There are some royalties for Dr. Zimmerman, but there is nothing of relevance with respect to conflicts of interest regarding the material that we're going to present. All the videos and photos that we'll be showing have the express permission of the children and their parents. We're going to start with the beginning. We're going to talk about ICU Liberation, the early days, by a visionary, Dr. Jerry Zimmerman, who was probably one of the first pediatric providers to begin focusing on these problems. That'll be followed by a need for change, reflecting the current state of PEDS ICU Liberation by Dr. Sapna Kujadkar, and talking about kind of how far we still need to go. We'll then get into the meat of the talk, which is the actual ICU Liberation Bundles, how we can implement A through F within the pediatric population, but also in different ICUs across the world with different cultures and different resources. For that, we have Dr. Betters, Dr. Long, and Dr. Morrow. We're then going to round out with a spectacular talk about quality improvement, safety, and importantly, sustainability. It's not just about implementing these protocols, it's about making sure people are still using them a year or 2 or 3 down the line. And then if there's time, I'll do a quick kind of case study of putting it all together, how we can kind of implement PEDS ICU Liberation in our standard everyday patients. And we'll end with a panel discussion where we'll open to questions from the audience, but also discuss amongst ourselves. And an explicit goal of this is to come up with some real ideas for research that we can be pursuing together collaboratively over the next few years. With that, I present Dr. Zimmerman.
Well, good morning, everyone, and thank you for choosing this session to attend out of many that are available. I'm going to kick this off by talking about what happened during the early years. So how do we make this go? Okay. So the learning objectives are shown here. I want to talk a little bit about quality improvement, a little bit about implementation, but you're going to get all the details of that later. But I do want to emphasize this idea of a bundled approach that's really key for ICU liberation. My main message, ding, 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 just pay attention to this one. There is a huge impact of this intervention that I don't think people are aware of, but should be the burning platform for why we go forward on this. And then close with some comments about waste, weaning, the shift in cost, and sustaining. So there are a number of risks from risk for adverse outcomes following critical illness. And of course, you would think, and it is true, that chronic comorbid conditions are key here, what the admission diagnosis is and what the severity of illness is when these kids come into our ICUs, and of course the intensity and the duration of organ failure. That's what we do in the intensive care unit. But what ICU Liberation is about how we provide our critical care, because it's life-saving, there's no question about that, but it is fraught with all kinds of potential adverse events because of the way we provide our care, and that's what ICU Liberation is all about. So just some facts. This ICU Liberation campaign was launched by SCCM in 2014 after publication of the PATIS guidelines which really provided recommendations for addressing pain, agitation, delirium in the adult intensive care unit. So this was a large, multi-center, collaborative, organized by SCCM. And the point of this was that the bundle, the ABCDEF bundle, really represented the implementation strategy for each of the recommendations, main recommendations in these PADIS guidelines. So key elements in all of this was that this was a bundled approach to quality improvement in terms of usual care for critically ill patients. And examples of this in our own world where the sum of the bundle works better than individual elements practiced individually is the CLABSI collaborative, huge impact on reducing childhood deaths in the United States, and more recently the Pediatrics Surviving Sepsis campaign, both good examples of bundled care. To do this, you have to have a team, an interdisciplinary team participating in this, and I would add, and I think this is very important, that these team members ideally should be practicing at the top of their skill set. The docs shouldn't be micromanaging everything that everybody does. Very, very key point, I think. And then lastly, this whole approach strives for a patient who's more awake, alert, interactive, and actually engaged in the care plan. So this approach, ICU Liberation, takes this focus of critical care medicine, which is on organ dysfunction and resolution. Again, that's what we do in intensive care. And with this new approach, adds this holistic element of care to the way we provide it in the intensive care unit. This is known as ICU Liberation. And my view of this is clinical standard work for the usual care that is provided to all critically ill and injured patients. So the PICU collaborative came about, had a lag time of about a year and a half from the adult group. Initially, there were 9 hospitals involved in this. And I would say for sure that when we started, there was completely variable degrees of knowledge, implementation, and performance for sure of each of the 6 bundle elements. This required, to be in this collaborative, required buy-in not only from ICU leadership, and another key point, but buy-in from hospital administration in general, interdisciplinary team again, and then SCCM set up these educational sessions where the 9 teams met monthly, virtually, sometimes in person sometimes, to discuss barriers and successes for implementing PICU Liberation. So here's the bundle. Everybody's heard of this, and I just want to reiterate quickly: A, always assess and treat pain. B, both spontaneous breathing and awakening trials daily. The pediatric interpretation of this is a little bit different from adults, and you'll hear about why that is. The choice of drugs that we use for analgesia and sedation. D is management, prevention of delirium. E is early mobility and exercise. And F, of course, engagement, empowerment of the family in the care plan whenever it's possible. Here's just some kind of highlights from what was going on in this initial PICU collaborative. Started off in March of 2015 and with an in-person meeting, and we were fortunate to have, I would say, several in-person meetings as we went along. In 2016, things actually got going. The specific aims, the inclusion-exclusion criteria for this initial pilot trial were confirmed. the data collection and the database finalized. The intervention phase, when hospitals started tracking performance of the bundle, began in October of 2016, and the intervention phase ended in June of 2017. Meanwhile, during this time, the very initial results of this collaborative were reported at the SCCM Congress in 2017, and then ensued a process of complex statistical analysis, manuscript composition, a recomposition, but I can tell you with assurance that I think the final iteration of this will be submitted today and hopefully available soon for all of you to read. So I'll begin with this slide. This is very important, and this is what I don't think people know that they need to know. On the y-axis is the proportion of bundle elements performed. This is one of two very important adult studies, but this is the outcomes: ICU discharge alive. The second, alive and discharged from the hospital, and then the third, overall decreased risk of mortality, in a dose-response fashion associated with performance of the ICU Liberation Bundle elements. Now, if you look at these odds ratios, I would challenge anybody to show me any study that has ever been more impactful in terms of outcomes for critical care. This is what our message should be in order to get all of this up and going once again. I can tell you that there is also a very statistically relevant impact on decreased mortality in the pilot PICU Liberation study, a dose-response association with improved mortality. However, the relationship to performance of individual bundle elements with that outcome is not nearly as strong as the adult data. So overall, there's nice evidence, particularly in adult studies, but some coming out in pediatrics, that performance of the bundle is associated with improved, patient-centered, clinically meaningful outcomes, almost any one of them that you can think of, but including survival, duration of mechanical ventilation, freedom from delirium and coma. When you leave the ICU, you have less risk of being readmitted. You actually need less restraints. And when you leave the hospital after you survive critical illness, you actually have a greater chance of going home rather than to a nursing facility. So let me talk about this in closing as I get close here. Waiting is the biggest waste in medicine. We wait for things all the time before we do anything to act. It's just a fact. So, in my view, the unwritten engine of ICU liberation is weaning. Weaning the ventilator, weaning the sedation, and minimizing the time that the patient is immobilized. It's proactive, not passive when we get around to it, but proactive, even scheduled maybe, weaning will reduce this waste of waiting. And by reducing the waiting, the value of our care will increase not only because quality improves, but this waste of waiting will be decreased, and that's increased value. Now with this, there's a shift in cost. Right now, a lot of the way we provide care is centered around pharmacology and specific medications that have their own adverse effects, costs that are important. With ICU Liberation, there is this alternative focus away from pharmacology and to people people beginning at the inside core with the patient, but a whole host of people that are valuable for distracting the patient, providing sedation or comfort, if you will, and then engaging them in exercise and mobility. And so the cost shift is from drugs to people, and that may be a difficult cultural change for many places to swallow. It's just a challenge. So, in summarizing here, what happened in the early days that has informed where we are right now is that there are strong adult and emerging pediatric data that says this works, and it is not a subtle effect. It's real and it's impactful. Weakness is not really weaknesses, but certainly challenge is that there are personnel needs to make this work. The personnel is a multidisciplinary team doing what all of them do best, but getting there takes some convincing. It's implementation science, it's culture change. The opportunities are clearly within this electronic health record. You can take this ICU Liberation Bundle, tweak it a bit for whatever, embed it in the electronic health record, and there you have your database for your quality improvement, continuous data flow to show what is happening. The threats are significant. There are competing quality improvement initiatives. After COVID, after this is our COVID, the current viral epidemic, we have less ICU staff, we have younger staff, we have less experienced staff, we have nervous staff that need to be encouraged that still this is the right thing to do. And then lastly, it's easy to implement and get things going, but it is a task, it is work to sustain any quality improvement effort. So with that, thank you very much for your attention. Look forward to your questions as we move through the session. Thanks very much.
Good morning, everyone. I'm Sapna Kachatkar. I'm the director of the PICU Up program at Johns Hopkins Medicine, and I'm thrilled to be able to talk to you today about the current state of the ADF bundle in pediatrics. So you might think this talk's a little superfluous. Obviously, the reason you're all sitting in this room is because you recognize there is a need for change with regards to how we do things in the ICU. But what I'd like to do is give you the lay of the land of where we're at right now. So I'm going to pause on this slide for a moment. You don't have to go searching for all of the literature on a daily basis that's directly relevant to PICU Liberation. I wake up every morning, I have an exhaustive search that I've developed that incorporates every aspect of the ADF bundle that has anything to do with pediatrics, and I add it to the list as relevant. So go to this list at any given day, and you'll see what the most latest and greatest is in this area. So I see the cameras are up. And they're going down, so definitely check that out. For example, the most recent PALIC literature is all there already, so want to make sure you guys all saw that. So I'm not going to focus on early mobility specifically here, but everything here comes down to illness doesn't mean stillness, right? We are taking care of kids during a formative time in their brain development. And I think you would all agree that everyone in the room, and some of you have heard me say this many times, would agree with this quote, that our ultimate goal is that we want children and their families to sustain the zest for living, which is a requirement for survival, right? And we don't always achieve that in the ICU the way they want. So where are we now? We need to understand that before we get to everything that my amazing colleagues are going to talk about, which is how do we get there and where do we want to be? So today, I'm going to focus on this specific paper that is relatively hot off the press. It came out a few months ago with many of my amazing colleagues that are sitting in this room, looking at the ABCDF bundle practices across many different countries, 161 specifically in 18 countries. So here you can see these are the sites that were involved for us to collect this data to help me give you the lay of the land of where we're at. So first of all, the reason that we did this survey is we wanted to understand from a liberation culture perspective whether we at Hopkins were the only ones who needed to change our culture, and obviously the answer is no. So the first study that came out, or the primary papers that came out of these, is the PICU study papers. These is the US, Canada, and EU papers that were published. Dr. Coletti is the PI for the Brazilian study. He's sitting up here in front. That is going to be in press very shortly. So PICU was a 2-day point prevalence study that essentially evaluated what acute rehabilitation practices were for kids who are in the unit for greater than 72 hours. So obviously the kids that are at highest risk. And so as you can see here, here's our US sites. And what we found was essentially we had a lot of work to do specifically in the mobility space. But one thing I really want to highlight, which is relevant to everything we're talking about in the bundle, is 62% of the kids among these 1,800 children on any given day in an ICU that were there longer than 72 hours were between the ages of 0 and 2. I mean, just take that in for a second. We are taking care of kids during the most critical time in their brain development and neurophysiologic development. And nurses and families, as you'll hear this theme over and over again, are the cornerstone of PICU Liberation. And we found that they're already doing the work. We just need to give them the tools to be successful. So also early mobility was safe. That was something, and I'm going to let my colleagues unpack that a bit more. So let's talk about practices across these 161 PICUs. So I'll pause on this for a moment. So I think there's some themes that you'll notice here. We're doing relatively well with regards to assessing pain, right? That's kind of the foundation and cornerstone of what we do as physicians. But how does that relate to the rest of the bundle elements? That's a question for you to ponder. In terms of spontaneous breathing and awakening trials, lots of variability there. Choice of sedation, this is specifically whether you're actually documenting sedation scores, not whether you're actually doing anything about them. Delirium monitoring and early mobility, big gaps here and lots of work to do there. We are awesome at family engagement, for the most part. There's definitely gaps, but as you know, PEDS is one area where we do engage our families at the bedside much more than our adult critical care colleagues. Sorry if you're here. And then finally, ABCDF bundle, the full bundle. It's like you didn't even notice this over here, right? Because it's so low. So what does it look like when we look at how people incorporate the different bundle elements? As you can see, there's really no theme here at all. So basically what we did is we looked at which units had which elements of the bundle and decided the proportion of that. So almost no one has incorporated the entire ABCDEF bundle, and everyone else has incorporated some permutation of the 6 bundle elements. So lots of variability in how we in our units have started to unpack and tackle this. So I won't spend too much time on pain because obviously we're doing a pretty good job with it. We do a great job with routine documentation, and you can see that there's some variability here from a geographic perspective, but across the board, we have a lot of variability in the tools that we use, and the biggest variability is among the frequency of assessment and documentation, and variability is going to be the big theme for the next several. Another area where there is lots of work to do, essentially in terms of both SATs and SBTs, the vast majority of us are not routinely doing these. Some of us do have a protocol for ERTs. In terms of ventilator weaning protocols, only overall 34% of units said that they had those. Whether or not they utilize them regularly is, again, a different story. And then who drives them, RT versus physician, et cetera. And I will just point out that this paper is also very hot off the press, and I see Dr. Kamani there in the room, so please do check this out. All right, let's move on to choice of sedation. Where are we at with regards to our sedation documentation and monitoring? And hopefully this isn't the case. This is what we want to move away from, right? It's not about our comfort. Here, we do a pretty darn good job of documenting the sedation scores. But the question is, who's documenting them? And are we talking about them on rounds, right? So we document that the nurses are doing this amazingly because it's part of they have to do the documentation, but the translation is where we are likely having significant gaps. And you can see here in terms of the frequency, we're all over the board. 2, 4, other. And then we culturally and in different countries have different preferences for which sedation tools we use. And that's fine, as long as they're validated. And fortunately, most of us are using validated pediatric sedation scoring tools. Sedation protocols, Very variable there as well. About half of us have a sedation protocol that we utilize. Most of us do a pretty good job with assessing withdrawal, and frequency of withdrawal and documentation is there. Delirium monitoring and management. This is a big area for us to work on. You're going to hear a lot of awesome information about how to incorporate this. Only 44% of us say that we do routine screening of delirium documentation. Based on the countries that you're in, you use different screening tools, but luckily we have many tools that are validated within our populations and a decent job of assessing and documenting. And I'll just point out very quickly that in our recent study doing a secondary analysis, a positive or lacking delirium screening was the only independent risk factor for a mobility adverse event. So delirium has to be addressed. Early mobility, this is a big gap. Only 26% of us have any sort of protocol pertaining specifically to early mobilization and rehabilitation. And in terms of dedicated staff, you can see here, 44% of us have a dedicated physical therapist. Very few of us have an occupational therapist. And given that we're habilitating infants and children, that's something for us to think about. And SLPs, also a significant gap. Family engagement. Family members can be at the bedside. We do a very good job with that. But how much do we actually engage the families on rounds? How much do we actually engage them in the activities that they're providing to their children? That's a different story. So are they given any sort of documents or training? Only 23% of units said they have anything that they can hand to families or talk to families about how they can engage with their child's care. So I'm not here to focus on implementation. You have fantastic colleagues who are going to talk about it, but I'll just point out very quickly this realist review that was just published focusing on effective implementation in the ICU Liberation Bundle. Again, lots of hot-off-press literature. You can always go back to that QR code that you just took a picture of. It's all there. And the take-homes from that study were essentially that we need a thorough understanding of the context. So I'm here to provide you the context, that we have a lot of work to do. That's the take-home there. So lots of room for improvement, guys. I have to say, I think you've identified that breathing, delirium, and early mobility are really low-hanging fruit for us to start to tackle. And again, it's not about sending one committee to work on delirium, another work to mobility. They go hand in hand. So we have to do this together as a bundle. Optimizing pain management before increasing sedation. We do an awesome job with pain assessment, but if we don't address pain first before we start snowing our pediatric patients, then we're really not making a lot of headway in terms of liberation. Consistency in sedation score and goal setting. We need to take the scores that our nurses are doing such an incredible job of documenting at the bedside and actually use that language to take care of our patients. If the SBS is a +1 or a +2, and the nurses documented that, the nurse shouldn't be coming to us and saying, the kid's flying out of the bed, will you give me something for sedation? But that's the culture that we, as physicians and APPs, have set up because we don't use those tools that they're documenting. And finally, multifaceted approaches, which is what you're going to learn about in the next several minutes. We are very excited that we have a 10-site PICU Up trial that's ongoing. John Birkenbosch is in the back. He's one of the site PIs. I think there's a few other site PIs in the room. But there's a lot of work happening, and you're also going to hear from my colleagues who are doing incredible work to look at implementation. Does it actually work? It might work at Hopkins, but does it work at other institutions if you do it the same way or differently? So lots to come. And let's succeed together. Thank you very much.
Hi, everyone. I'm super excited to be here. I'm honored to be among these esteemed presenters. I'm a pediatric intensivist at Vanderbilt University Medical Center. I am the upcoming co-chair of the ICU Liberation Committee, and I was in the PANDEM guidelines group. So I'm going to focus on the implementation of the A through C elements and talk a little bit about our recent guidelines. So today we'll review the PANDEM guidelines, and as Sapna referenced, the new pediatric vent liberation guidelines as well. You can't talk about the B element without talking about those. And then we'll discuss some methods to implement the A through C bundle elements. So we've talked a lot about the ICU Liberation A through F bundle, and this was always intended to be a way to implement the guidelines. So when we were doing the PANDEM guidelines, we really wanted to be synergistic, and so these things work together. I'm only going to talk about A through C, but it's a bundle and everything interplays, so it's very hard. So you'll see there's some overlap, and we'll try not to speak too much about D, E, and F because my colleagues are going to talk about that next. I also want to highlight our website, which is on the bottom. It looks a little small, I'm sorry, but if you Google ICU Liberation, you'll get to our website. Over the past couple years, we've made a conscious effort to increase our pediatric content on that website. And so each bundle element has a separate page. The scales that I'm going to talk about today are in there, so I encourage you to take a look. So the last year has been super exciting for pediatrics. We've had 2 huge guidelines published that are very important for our patients. And so the first was the Clinical Practice Guidelines on Prevention and Management of Pain, Agitation, Neuromuscular Blockade, and Delirium in Critically Ill Patients with consideration of the ICU environment and early mobility. I'm just going to call those the PANDEM guidelines from here on out because that's a mouthful. And we were chaired by John Birkenbosch and Heidi Smith, who were wonderful, and I know John's here today. And then I also want to bring up the International Practice Guidelines for Pediatric Vent Liberation, which came out of the Policy group, which is also very, very helpful as we talk about the B element. So the PANDEM guidelines is a really large document. It was a lot of work over several years. I actually got added to the group after they had already been working for a very long time. It was a large group of people who put in a lot of work to look at all the data. And so it's a little overwhelming when you first look at it, and we moved a lot of the information into supplemental digital content. So as I talk today, there's not a lot of time to get into the nitty-gritty, but I encourage you to go check that out if you're interested about exactly what studies and what the data was. But I do want to point out that figure 1 in that document was meant to help with the approach at the bedside. It's not covering everything because it's impossible to have it all in one clean figure, but this is the high points, and this was meant to help you when you're implementing this in your unit. So this is taking a step back and looking at it all together, but I'm going to zoom in on a few portions of this today as I talk through the bundle elements. So A stands for Assess, Prevent, and Manage Pain. In the PANDEM guidelines, our recommendation really is the analgo sedation approach. So Sapna talked about this too. Treat pain before sedating your patient. That is imperative. And so to assess our patients for pain, we need to use reliable, validated scales. Self-report is the gold standard. So if your patient is able to self-report their pain with the scales I'm going to show you in a second, that is what you want to do. If they aren't able to self-report, don't rely on just vital signs. It's not accurate, and we want you to use validated observational tools because remember, sedatives can change vital signs. So here is a list of the self-report scales that are validated in pediatrics that the PANDEM guidelines recommends, and then the observational tools, the FLAC and the comfort behavior scale are the ones that we recommend for that. As far as frequency of pain assessments, this came up when Sapna was showing her data, there's no recommendation on the frequency, but I will encourage you, at our institution we do every 2 hours, but if a patient's having a procedure or if their pain is rated high and we're doing something to treat it, we monitor it more frequently. I would recommend having some sort of policy or protocol in your unit to standardize how often you're doing pain assessments. So for treating pain, the pharmacologic recommendation for moderate to severe pain is IV opioids. There's actually moderate evidence for adjunct NSAIDs in postoperative children for reducing pain scores, and then a small amount of evidence for adjunct acetaminophen as well for postoperative patients. And then for NSAIDs and acetaminophen, there's a low level of evidence that when you use them as adjuncts, they will reduce the opioid dose that your patient needs as well. And then non-pharmacologic, please publish what you guys are doing because I know that people do lots of non-pharmacologic pain management in their units, but there's just not a lot of data. Interestingly enough, there's moderate data for music therapy and specifically post-operative patients, and then non-nutritive sucking with oral sucrase for infants during invasive procedures, which I know we all know, but when you're doing guidelines, you have to go with the literature, so I encourage you to publish what you're doing. So now that brings us to the B element. So the B element stands for both spontaneous awakening trials and spontaneous breathing trials. But I grade out the spontaneous awakening trials. This is where we really differ from the adults. So the PANDEM subgroup that looked at this, there were 5 pediatric studies looking at daily sedation interruptions, or DSIs. 4 out of 5 of those had a high risk of bias, and then there was one that had a moderate risk of bias that was an RCT that actually saw increased mortality in the group that got DSIs. So with that, we didn't really have any data to recommend this in children, and so Our recommendation is using goal-directed sedation. So using sedation scales, setting a goal, and everybody working towards that goal. There also is a period in our PANDEM guidelines where we talk about the peri-extubation period. So this is a time when you're reducing sedation because you're planning on extubating your patient, and this is where we often have unplanned extubations in this time period. And so the recommendation was to have a target depth of sedation and increase your frequency of monitoring their sedation level. And then consider a sedation weaning protocol. I'm going to talk a little bit about that as a formal recommendation, because patients who wake up who are agitated and withdrawing are at higher risk of losing their ET tube. And then having unit standards for how you secure your endotracheal tubes, and restricting nursing workload, which is really hard. But in this time period when you're reducing your sedation, if your nurse can be in that room with that patient, that will protect them as well. So for the spontaneous breathing trials, I am going to reference the guidelines for pediatric vent liberation here. They had 14 recommendations in their document, and the first 3 were considered core recommendations. So the first one is use a protocolized screening method to assess when your patients are ready for an extubation readiness test or an ERT. So, you know, we're humans, and to Jerry's point about waiting, you don't want to wait until you recognize that your patient's ready for it. Have a screening method to when they should get an ERT. And then use a protocolized ERT bundle that should include an SBT. Other things that might be in your ERT bundle, and they outline this in their document, are things like, what are your patient's secretions? Do they have a leak? Are they at risk of post-extubation airway edema? Things like that. What's their muscular strength? All of those things can play into your ERT bundle. And then the other recommendations, the 4 through 15 recommendations, I don't have time to go through all of them, but they're wonderful, and I encourage you to look at it. But it's things about like how much pressure support should we be using, and they really unpack what we have evidence for and what we don't. So that brings us to C, the last element that I'm going to talk about today, and that's choice of analgesia and sedation. So again, these all interplay. We already talked about analgesia in A, so I'm not going to talk a lot about that, but I want to talk about sedation drugs and monitoring sedation scores. So we recommend using a validated sedation scale. So the 2 that have the strongest evidence in literature in children are the Comfort B and the State Behavioral Scale. There's a conditional recommendation, though, for the RAS as well, which is what a lot of adult ICUs use, and there's some pediatric data for that as well. But the biggest thing is set a sedation goal. Everybody should be speaking the same language, working towards the same sedation goal. And then when it comes to protocolized sedation, the PANDEM subgroup that looked at this, there were 10 pediatric studies at the time when we reviewed the literature looking at sedation protocols. And when they pulled all the evidence together, there was a low level of evidence to support using a sedation protocol. So we talked about analgesia already in the A, and so now I'm going to talk about the actual drugs for sedation. So in the PANDEM guidelines, we did recommend alpha agonists as the first-line agent. So dexmedetomidine is usually what most people are using, at least in the U.S. And there's very good literature in post-op cardiac patients, especially those that you're trying to fast-track on extubation, that dexmedetomidine is superior. As far as other critically ill children, there's a low level of evidence for the use of dexmedetomidine over other sedatives. For second-line therapies, the recommendation is ketamine, propofol, taking into consideration the risk for propofol-related infusion syndrome. So actually talk about minimizing your dose, minimizing your duration. There's actually a fair amount of evidence to support, if you use it carefully, that it is safe in children. But we definitely need more data in this field as well. And then benzodiazepine exposure. So I think most people know that benzodiazepines in higher doses and longer durations are associated with development of delirium in critically ill children. But when used thoughtfully, they can be good sedatives as well. So just taking that into consideration. As far as neuromuscular blockade, we do have some guidelines on that as well. We know that neuromuscular blockade has negative consequences for our patients. It increases their risk for ICU-acquired weakness. It takes away our ability to assess them for pain. It takes away our ability to get a neurologic exam, and it takes away our ability to see how well they're sedated. So they're not, we don't love using these drugs, but we also know that there are clinical situations where we need to use these drugs for physiologic reasons. So if you are using it, use the lowest dose possible and monitor your patient closely. This is another area where there's a real lack of pediatric literature, but we do recommend using train of 4 to monitor the depth of your neuromuscular blockade, and then consider use of an EEG to assess your patient's sedation state underneath of the neuromuscular blockade. Of course, make sure they have adequate sedation and analgesia, which is easier said than done, I think, in real life practice. And then eye protection, save the eyes. So remember, these patients are at real high risk for exposure keratitis, so making sure their eyes are moisturized, using eye shields if their eyes are open. As far as iatrogenic withdrawal syndrome, recommend using a validated screening tool for that in children. So the WOT1 or the Sophia Observation Scale for opioids and benzos are recommended. And the guidelines actually call out to remember that even if your patient's been on sedation or analgesic drugs for less than 5 days, if they've been on high doses, they're still at risk for withdrawal. So don't forget about those patients and screen them as well. And then the other thing I want to point out is that these tools aren't validated for use in dexmedetomidine and withdrawal. So my fellow Chiara Velez actually did an abstract on Saturday. We've been taking a deeper dive into our data, trying to define what does alpha agonist withdrawal truly look like, and we need a validated tool for this very badly. As far as alpha agonist withdrawal, I will say we mentioned looking for unexplained hypertension of tachycardia because that has been described in case reports as a sign of withdrawal from that as well. And then a standardized sedation weaning protocol. In the past few years, we've had some good literature come out showing that this improves outcomes in pediatric patients. So I would encourage you, that as part of the guideline recommendation, I think we're building data on that as well. We're doing a cost analysis right now on our sedation weaning protocol. So that was a lot of data in a short period of time, so I'm just going to hit the high points for you as we're closing out here. So for A, use validated scales to assess your patients for pain, and self-report is the gold standard if your patient can do that. And remember, treat your patient's pain before sedating them. For B, we don't recommend a spontaneous awakening trial in children at this time. That could change as the evidence changes over time, but for right now, no SATs in children. But we do want you to use protocolized screening for ERT readiness and spontaneous breathing trials as part of an ERT bundle on your pediatric patients. For C, use validated sedation scales, set a goal. So we're all speaking the same language, and use a protocolized sedation in your unit that everybody's on the same page as far as what your goals are. And then don't forget to monitor your patient for iatrogenic withdrawal symptoms. So this is a lot to do in real life practice. As we already see, we're struggling to implement these things. There are many, many barriers, and I want to give you guys some resources. So again, the ICU Liberation Committee, we've been working hard to build our pediatric resources. So I want to point out, if you go to our website, there's an implementation toolkit that's for peds and adult. And as part of this, which you may hear about, there's something called the MDS, or the minimum data set, that you can track your compliance. But we have also recently, over the last couple years, we've been working with Epic and Cerner to create ICU Liberation builds in the EMR, and those are officially released for the pediatrics versions as well. They do take some IT support to build into your EMR, so if you're interested, go to our website, talk to me. I'm happy to help with that. But again, sustaining some of these things, if you can build it into your EMR and track compliance, that will help you with sustaining the implementation. And then lastly, just bringing it all together. So it is hard work, and I want to remind you why we do it. So these are some of my patients reaping the benefit of PICU Liberation. So the first one's a young man with acute on chronic renal failure and ARDS, secondary to histoplasmosis pneumonia, and he is coloring dinosaurs. He loves dinosaurs, one of my favorite patients ever. The middle patient's a post-op cardiac patient who is doing developmentally appropriate activities while she's intubated in a tumble form. And the last patient was a young lady with end-stage pulmonary hypertension who's on VV ECMO, and she's in our garden drinking a milkshake on VV ECMO. So this is why we do it. It's not easy, but remember this as you're going forward with this and you're meeting barriers. This is the point of it all. Thank you.
Hi, my name is Debbie Long, and I'm from Australia. My background is PICU nursing, and I've done that for about 30 years. In the last few years, I've just moved into academia. And I'm delighted to talk to you today about delirium and how we've been implementing our assessment, management, and prevention in our unit. So just to let you know before I start, there's quite a few videos in this, and all the photos and videos have permission of the families, parents and children where able. But really what Jerry has pointed out to us today already is that delirium is avoidable and also treatable if we do get it. So, and there's very good evidence now in the adult literature that regular screening, assessment and prevention, can minimise delirium significantly. So we've now got some new emerging paediatric literature that's shining more light on this concerning problem. So for children, the assessment of delirium and the diagnosis of delirium is essentially similar to adults. We still see the three subtypes of delirium being hyperactive, hypoactive, and mixed. The difference is that in children, approximately 50% of those are hypoactive and another 40 to 50% again are mixed, and we don't tend to see so much of the hyperactive symptoms. And in terms of paediatrics, some of the considerations that we need to take on board is their ability to communicate, whether it's their age or their level of cognition, whether they have a ETT in or a mask on their face, the typical stranger danger or their developmental stage where they may not want to communicate or express any concerns with anyone else other than a trusted parent. And the other thing that we need to take into consideration is different developmental stages and whether the child has developmental delay as well. And I really, at this point, want to point out a survey done by Sapna's group looking at several cardiac PICUs over 13 countries, and they found that a lot of the time, and I said that hypoactive symptoms were actually the most common symptoms that we see, or subtype that we see in paediatrics, but these are unfortunately also the most commonly missed. And so, we've heard people talk already today about validated screening assessments and standardised tools and standardised protocols, and you're going to continue to hear that from each one of us and talking the same language. And it's only by implementing screening assessment tools that we can start to pick up on these hypoactive symptoms. There was little routine rounding done around delirium, and again, this is about sharing the same language and having the communication link between the nurses and the doctors and the medical staff understanding what tools are being used. 75% of units did not routinely screen, and only a very small percentage always screened. And in this survey, most of the attendings were the ones that did any sort of screening. And as Sapna has pointed out, that actually the people who are with the patient all the time are the nurses and the parents, and so they're your biggest ally. So, as I mentioned, validated screening tools. There are quite a few now that we have the luxury of accessing, and in the PANDEM guidelines, specifically the CAM ICU suite, so that's the pediatric and the preschool confusion assessment method in ICU, and then also the CAPD. We do have the SOSPD, but the PANDEM is recommending the CAM ICUs and the CAPDs. Both well validated and used frequently across a lot of the units now, as Sapna has showed you with what's happening at the moment. Sorry. However, one of the limitations that we've found is that in the literature we know that there's evidence for these screening tools, but they were developed by highly trained individuals, which is great, and also all of the literature that was coming out about the reliability and the validity of these tools was from the actual units where they were developed. And so a question I often get asked by people is, well, what tool should we use? And there isn't a right answer or one answer for everyone. You have to look at those tools and how you could implement them in your unit, and what your makeup of your staff is and the culture. And so we did exactly that. We took both of the CAM ICUs for pediatrics and preschool and also the CAPD and implemented them in our unit. The nurses loved me for it. And we had them assessed against the gold standard DSM-5, and we had a psychologist doing that, not psychiatry. And the reason is that our psychiatry consultant liaison team said, well, you know more about delirium than we do. And they weren't as engaged in the ICU, they were more sort of outpatient care. So fortunately we had a very actively engaged psychology team, which turned out to be great because, in talking to and touring around a lot of other units that are really great at implementing delirium assessment and treatment and prevention, psychology just brings a different perspective to it. So we were able to draw from the psychiatry work that's been done, and Christina did present some of that the other day, but psychology really brought in that family-child, parent-child dyad and child neurodevelopment perspective to the delirium piece, which has been really great. So you can look up the results of what we found, but this applied to our unit. But in actual fact, we use two different delirium screening tools in our unit. Our default that everyone uses at least twice a shift, done by the nurses, is the CAPD. And then if there's any concern or query or I'm not sure, then we've got a significant number of other people within the unit that can talk them through that and either confirm or as a second check use the CAMs as well. One of the other things that we found with this study is that the discordance, so where we had disagreement with the gold standard, was related to, and this is really not surprising, or shouldn't be surprising for people, is a younger age. So we had more disagreement when the child was the youngest age, when they were on sedation, and when there were symptoms of subsyndromal delirium. So when they were either just tipping into delirium or just tipping out. And so we were able to use that evidence from our own unit in our own study to say, okay, these are our trigger points where we really need to focus our education is around the most youngest child. And obviously, Sapna's pointed out that most of our children are under 2 years of age, and they are really tricky. So we've really leaned in heavily on the developmental matrix that Chani and her team have developed to go along with the CAPD and integrated that into our medical information system. Sadly, we don't have Epic Cerner. We have a different one, just to be a little bit more challenging, but we've integrated that in there. And that has been a bit of a game changer for us. So instead of the nurses reading the standard default CAPD, they will actually read the ones with the proper developmental milestones in them. So some of these assessments that we've practiced, and we use these videos as education for our staff as well. You'll see us doing, it's usually me doing the assessments on some of these children. So as I'm talking, I'm not going to necessarily talk about the videos. See if you can pick up some of the features that the kids are displaying. And so in terms of the prevalence that we understand, and again, Christina and Stacey and even Peter covered, quite a extensive bit of information on this the other day. We see a wide variation in the prevalence of delirium that's reported in paediatrics, and sometimes that's likely to be because people are just reporting on observation of clinical symptoms. So you see the really low prevalence, and it's likely that they're missing those hypoactive symptoms. It will often also depend on the type of unit that you're seeing. So there's strong evidence to show that there's a higher incidence or prevalence of delirium in cardiac units, in particular surgical in this case. And then there's been a more recent systematic review which has actually pulled all those prevalence papers together to show us a pooled prevalence of around 35%. So again, we do have a long way to go to minimise that. Certainly there are some risk factors that have been identified within paediatric cases, and all of these are really useful to sort of educate your staff on who they should be targeting. I mean, in our unit, we don't do delirium assessments on certain patients. It's every patient. I know people started to try and tell me in the beginning, oh, we only do it on ventilated patients, but there are other risk factors. And when we started seeing delirium in non-ventilated patients, the staff sort of got the message and the picture. So obviously I said that the younger children are at risk. Those with a developmental delay are also at risk, and when we think about the other end of the age spectrum, we've got our elderly patients and the dementia, and that's also a risk factor as well. So if we think about older age, younger age, dementia, developmental delay, they seem to be the concerning areas, and other comorbidities. There are some emerging illness-related factors, but we can't modify some of those things. So the areas that we can really pay attention to are the areas that we can, where there's the modifiable risk factors. And so we've heard already Christina talk about benzodiazepines, but it's not just the only drug, there are other drugs. We've heard about pain control. And again, we've already heard today how you can't look at delirium in isolation, you need to look at it factored in against all the other elements of the bundle. And it's not until you can get that synergy with all of those bundles that you really start to see the impact. And as Jerry pointed out from the adult paper, and hopefully we'll see in the pediatric paper soon, is that dose response. So every little bit more that you can do in terms of each individual bundle and the elements within those, the more impact that you are going to have. And I know Christina talked the other day about, or maybe it was Stacey, about the brain maps. There are actually sort of tools that we can use to help think through what might be causing this delirium. I get lost in things like brain maps. I don't know, maybe I'm a bit simple. And I often just think of the three sort of overlapping areas of, what does the illness or the injury that's actually going on with the child? Is there sepsis, inflammation? Are they an oncology patient? What are the treatment factors that come along with that? Are we giving them sedation? Are they having chemotherapy? Are they having steroids? And then finally, what environment are they in? And obviously the ICU is noisy and bright. And so a lot of the things that we talk about are those environmental factors that are modifiable that we can address. I know this is more about implementation, but I think having and educating our staff, particularly about the mortality and the cost of delirium. We know that delirium is a strong and independent predictor of mortality, stronger in one particular study than our PIM. We often look at our PIM or our PRISM or our risk of mortality, and this has been shown in one study to be a stronger predictor. And we know that about 85% increase in PICU costs, even when adjusting for severity of illness and length of stay, those sorts of things, that every day a child has delirium, the cost of care goes up incrementally. So, there's huge evidence here why we should be minimising it. But to me, the evidence of why we should be minimising it, yes, the cost is important to understand, and obviously mortality is important to understand. It's the burden on the child that survives, and also on the parents, because we can't look at children and parents in isolation. We have to look at the family unit. So there's mixed evidence about neurodevelopmental outcomes after experiencing delirium for children. So there was one particular study that found no association with cognition and behaviour and delirium. But there have been other studies done here in the States that have seen a strong association with a decrease in cognitive status, but that was measured with the PCPC. In the previous study I mentioned, there were quite comprehensive, validated face-to-face neurodevelopmental assessment tools. There is definitely evidence about a reduction in the quality of health-related quality of life. And then some work that we've done in our own unit has looked at child outcomes out to 6 months. And within that, it's not published yet, but we're working on it. We're seeing a trend towards a higher intensity of post-traumatic stress symptoms, particularly in children older than 7 years. Whether that's cognition and memories of being delirious, because children do remember some of their thoughts and processes while they have been delirious. It's not all a blur. And they often need help putting those pieces back together, but in the right order, and not correcting them, but sort of restructuring and almost re-scrapbooking their time that they were in ICU. And we've also found a significantly poorer quality of life. We've also done some work with our parents, and this is the interesting component, is that with parents, even at 2 weeks, had higher anxiety symptoms, total depression tended to be higher. There was no difference in the groups, those that were delirious and those that weren't, in terms of stress or PTSS, but with the post-traumatic stress symptoms, they had a higher severity. And they definitely had poor coping and adjustment as well. But all of those differences disappeared by 6 months. So we know that it's definitely impacting both the children and the families, at least out until 6 months. So in terms of the treatment, you know, we've talked about brain maps, or Dr. Dre, there's so many acronyms, and the 3 circles. And essentially what that's acknowledging is that it's a multifaceted problem. You go to some of the delirium conferences and they put up the big pathway pictures of 10 million bits and pieces all contributing. I can't work with that. But to know that there are multiple causes, and because of that, you need to take a multifaceted approach. There's not just one thing that you can do. Similar to the bundle elements, you should be layering them all on top. And so what we tend to see, again, is that focus on the non-pharmacological modifiable features, particularly around the environment. There's not really any evidence, again, for pharmacological treatment. And again, the PANDEM guidelines state this quite clearly. There are some small studies with some off-label antipsychotic use. And the biggest thing about using the first line or the atypical antipsychotics is consideration of adverse events. And typically the recommendation is not to consider pharmacological agents in terms of the antipsychotics unless you have protracted distressing delirium. So for us in our unit, we rarely see it used, and everyone is pulling out all stops to look at the non-pharmacological methods first. And essentially prevention is the same as treatment. There's not 2 different sets of rules, but in essence it is early recognition, and you can only do that with a validated assessment tool that has been validated for the PICU. So what I'm getting at here is that there are some other validated pediatric delirium assessment tools, but for example, the post-anaesthetic tools have really focused in on that hyperactive symptomatology. So the recognition with PICU being predominantly hypoactive, those tools have been developed to capture those symptoms. And you know, the recommendation is at least once per shift. In our unit, we do it twice. Obviously, we're in a liberation session, so it would be remiss of me not to say the bundled approach is the way to go. I actually started trying to implement delirium screening 2012, I think, maybe, you know, very early on, and maybe 2013. And I just tried to do delirium alone, and I had just tried to do sedation alone. And it wasn't until the Liberation Initiative here started rolling out that we started looking at it and thinking, okay, this is why it's not sticking and not working, and it's not hanging in people's heads, is because It wasn't all fitting together. And so we didn't have our aha moment, thanks Oprah, until we started looking at it all together. We had to. For me as one person, I thought I can't roll out all these individual elements. But then once I found key leaders in each of the other areas and we rolled it out all at the same time was when we really started to see the gains. And the nice thing is that there are some little quality of improvement studies, and I know for the people who published these papers they weren't that little, but that show that we can implement simple rounding checklists at the bedside. We can implement noise reduction strategies, looking at delirium, sedation, and pain alone. So not necessarily all elements of the bundle. People have significantly reduced the incidence of delirium in their units by little quality improvement activities. The other thing is sedation stewardship. Again, we've already heard several times about setting daily goals and making sure that we're all talking on the same page. In our unit, and I mean, I know we've already talked about sedation, but you can't do delirium without talking about sedation. We have a default. The default is your sedation score is 0. We use the RAS. And unless someone else says your aiming and your goal is 0. But that goal is discussed and set every morning with the ward round. And then we have a liberation round in the afternoon where we look to see how people are meeting their goals. Obviously, we have other goal setting as well. We have early mobility goal setting. And we check in with the staff and the family at the bedside to see how they're reaching those goals, if they've swayed from them, if they've exceeded them, and how we can help them reach them or move to the next level. And then obviously there are other things outside of liberation like music and games, and this is all about being a child, getting back to basics, massage and reading. I've talked about education, and I can't emphasise this enough, and not just for the staff but for the parents. Educating the parents about what delirium is, what it looks like, and they are actually the first person that might pick up on something. This is not my child, is commonly something that we hear from the parents. So to engage them very early in the piece about delirium and what that is extremely important. And we find the CAPD tool a really great place to start in terms of what their normal behaviour and arousal and awareness is like at home. But we know that delirium is an area where there's a huge amount of variability. We know that there are units that are still not implementing it, and we know that there are still deficits in our knowledge from a clinician perspective. So we've got more work to do. But as I said before, our bedside nurses are the most ideally placed to do our preventative work and also our screening. So we do need to, as a first step, take-home message from my session is if you are not screening, you need to start doing that. And obviously there's one thing to say you're screening, but to do it reliably is a really important piece. So like I said, I've implemented delirium almost 10 years ago now, but not a 6-month has gone by where I've not had to go back into the unit and keep training and educating the staff, because we have staff turnover, things change, the world changes, people get distracted with other initiatives and tend to fall back into old habits. So we need to constantly be educating and updating people, and of course new evidence rolls in all the time. In terms of implementation, this is drawing on my experience, there's no in particular evidence. This is the last one. Is understanding the unique barriers to your unit. So talking to your staff about what are their concerns and fears. And this is not just implementation of delirium, this is in general. So I'm sure some of the next speakers will mention this. Acknowledging and rewarding the early adopters. People say, you just need one leader. I say, you just need one follower to really get this stuff going. And we've found great success in highlighting patient and family narratives. So we have a weekly newsletter, and we are constantly putting in information about achievements that staff have made in terms of liberation and also families as well. And we also appeal to our staff as the ideal clinician. And we have found specifically, and we've done all the organisational surveys and things like that, that participating and providing PICU Liberation is providing meaning-making for our staff. We choose one bed and we work outwards, so we focused on one bed and having all the elements, and obviously for delirium, exactly how we wanted it to, according to our protocols, in one bed, and then we moved out and out and out. So we always knew that bed 10 was the liberation bed, and we provide extensive support and training and education, and important to that is feedback, constant, timely feedback to your staff. We've all finished on slides that talk about resources, and I'm going to add to that. So if you want to take a photo, so we've got the Pandem guidelines, we've got the up-to-date literature, we've got the SCCM webpage. These are all fantastic places to go. There are other delirium web pages, and we've had podcasts, which are a great source of information. The other thing is reach out to people. There are numerous people in this room and beyond who, even just for me in Down Under, where people tend to forget where we are, that have been a huge source of information and support in trying to implement these sorts of things. So reach out, ask people. Thank you very much.
I'll have to lower it again because I'm a bit shorter. My name is Brenda Morrow. I am a clinician scientist with a physiotherapy background from South Africa, and I'm delighted to be speaking today on the E and F of the Liberation Bundle. So you've seen the bundle, and again, I can reiterate, you cannot see the E and F factors, that's early mobility and family engagement, in isolation from the rest of the bundle. But I am going to be focusing on that as per my mandate. So we've heard a little bit about the whys, but I think certainly in terms of early mobility, it's really important to emphasize why it's so important. Because if we really understand the why, it becomes much easier to actually do it and to implement it. This was a small systematic review we did a couple of years ago, which really just showed that what we know, that PICU mortality has been declining steadily over the past years. Unfortunately, it's much more notable in high-income countries, which is the red line in this graph. Low and middle-income settings are lagging far behind. But I think it's safe to say that mortality in the pediatric ICU is becoming relatively rare, which is obviously fantastic. But we also know that simply being alive is not the same as being able to live life to the fullest. And so we need to look at functional outcomes, not just surviving. How can children thrive after their ICU discharge as well? If we look at immobility alone, and we see these effects in the astronauts after space missions, immobility alone without the critical illness can affect adversely every single organ system, with respiratory stasis, secretion stasis, infection, embolisms, cardiovascular effects of postural hypotension, for example, neurological effects, delirium, depression, anxiety, musculoskeletal complications, including osteoporosis, severe muscle weakness and atrophy, and joint contractures. And those short-term complications of critical illness and immobility may persist in the post-intensive care syndrome. So this we have known about in adults for many, many years. More recently, Joseph Manning and colleagues have applied and conceptualized this concept in the PICS-P framework, the pediatric framework. So we know that these consequences of critical illness and immobility may affect your physical health, cognitive, emotional, and social health adversely in the short and in the long term. And this may have considerable impact on the child's ability to function in everyday life and on their neurodevelopmental outcomes. Importantly, it doesn't just affect the child. It also affects their siblings, their family, and their extended community. And the trajectory of recovery is highly variable and may last days, weeks, months, and possibly even decades. So if keeping still has so many problems, surely it makes sense to work against that. And that's really the premise behind early mobility and rehabilitation within the PICU. By incorporating movement, active exercise into our critical care, we're really aiming to improve outcomes, improve duration of PICU stay, improve duration of mechanical ventilation duration, and importantly, allow children to be able to be children and function appropriately on discharge from the PICU. So we ask the question, what is early mobilization? And I get this a lot. And there have been variable definitions, from applying physical activity within the first 48 to 72 hours, or the more pragmatic definition from my colleague in the front, Karen Chung, that really it's mobilization that's initiated as soon as possible after admission, when it's safe to do so in the absence of contraindications. When we ask about safety and efficacy, unfortunately, and this is the case in so many aspects in pediatrics, this bundle element is not supported by high-level evidence. Empirical studies in this area are really challenging to do in the first place, but we have relatively few pediatric-specific studies. Most of the studies we have are relatively small, and I'll come to the PICU, which are somewhat different. Observational studies, many are retrospective studies, limiting the strength of evidence that we have in support of efficacy. We do have a number of smaller studies that have been combined in systematic reviews, which suggest benefit, and certainly our adult studies have shown benefit for a number of outcome measures. But these smaller studies together really do suggest that early mobilization within the PICU is both safe and feasible. And as I said, we don't have robust evidence in support of efficacy, but if we look at the evidence table, scientific rationale, expert opinion, and experience is part of our evidence base. It makes physiological sense and clinical sense to mobilize patients. And in the absence of harm, we need to start practicing. The PICU studies of mobilization practices, again, and we've heard this from Sapna earlier, have really only reported minor adverse events, and many of these are transient changes in vital signs. And even in specialized populations, such as those on ventricular assist devices, post-liver transplant, and ECMO, have also not shown serious adverse events. So I think it's safe to say that it appears to be safe. When we look at who should be mobilized, well, it's interesting is that a number of studies have shown that early mobilization is more strongly supported and practiced in older children, and really that younger infants seem to be relatively neglected in terms of implementing early mobility. So what about the infants? So the child on the left is my own daughter some years ago when she was 4 months old, and at that same time in our ICU, we had a child of that identical age, oscillated. Look at the amount of movement a normal infant engages. They spend hours every day moving, both voluntary movement and involuntary movement. And that movement is essential for the acquisition of normal neurodevelopmental milestones, for gaining muscle strength, for lengthening muscles, and maintaining joint integrity, as well as cognitive benefits and other benefits. So I think that not only should infants and young children receive early mobility, I actually think they need to be specifically targeted for early mobility practice, because we tend to forget about them. The other people that may benefit more from early mobility, and we don't know this empirically, are the long stayers. The problem is, and we've shown this in our unit, that on admission, one cannot predict who is more or less likely to be a long stayer. And if we wait, the problem of waiting, you actually miss the boat. By the time you realize that this is the child that's going to be spending weeks or months in your ICU, you may already have the adverse sequelae. So we do need to start as soon as possible for all our patients. So for me, the who is everyone. All patients who are admitted to the PICU should be assessed for early mobility intervention, and this should be implemented as soon as it's appropriate to do so, regardless of age, regardless of premorbid functional level, regardless of their condition. But the nature of the mobility needs to be appropriate to the child as they present to you. So my story is that I have always mobilized children. I think maybe it was naivety. When I started practicing in 1996, I walked into a pediatric ICU, having never stepped into one before, and was expected to run the physio program alone. I had children that were lying there not moving, so I moved them. And it was only almost 20 years later that protocol started to be developed, that people started to wake up to the fact that this was important, at which stage I was giggling in the back, saying, well, we've kind of always done this. But I certainly think that there's safety in protocols. There's safety in knowing that you're practicing in the same way as other people. And so I was delighted to be invited by my esteemed colleague to join this group to develop practice recommendations for early mobilization in critically ill children based on available evidence and expert consensus. And this really is very comprehensive. It provides all the contraindications and precautions that you need to understand and the indications for early mobility. It provides you with a recipe, really, on the type of activities that we might be doing with children in different contexts, as well as providing stopping rules. When do you need to step down and realize that this is not appropriate for this child? In summary, though, we do recommend that early mobilization should be commenced as early as possible following the PICU admission. And really, early mobility or rehabilitation is a progressive approach. It's a graded approach according to how your child is presenting. And remember that children will change from day to day. So although you might think it's a one-way progression, it's not always a one-way progression. If your child is acutely ill, if they are sedated and they need to be sedated, one could start with passive interventions, active holding in the parent's arms, passive range of movement exercises, positioning appropriately. And as the child's condition changes and improves, one can then start incorporating activities that require greater participation on behalf of the patient and greater active participation. Now, in adults, the goal of mobilization is usually independent ambulation out of the bed. But remember, we're dealing with a range of ages from birth, and in some units up to 18 or even beyond that. And so that cannot be your goal. You have to set your goals of mobilization according to your individual patient and based on a full clinical assessment. And we need to remember that mobility activities include pre-ambulation activities appropriate to the child's developmental level. A lot of people will say, well, we can't do it because we don't have the equipment. And I do note that many of the published studies use fairly expensive equipment like cycloergometers, gaming consoles. We've never had those. And I don't believe that they are necessary in order to achieve your mobility goals. I think it's nice to have, but as I say, we've been mobilizing patients forever. When I started working, we didn't even have standing frames. Even now, you can see we use very simple equipment. I believe that all you need is your own body and a willing and capable team. Please excuse lack of PPE. This was before COVID, and our rules have changed somewhat. This little girl had a high spinal tumor, and at this stage, although it looks like she's actively participating, in actual fact, she had grade 0, at the most grade 1, muscle power below the neck. She was highly motivated, however, and said she at least wanted to be able to move her own wheelchair. And so she asked every single day to get onto the floor and work. I think yoga helps a little bit in getting your body positioned appropriately, but I say you don't need expensive equipment to do what's necessary. The one slide seems to be missing here, but never mind. Play is so important. Play is a child's functional activity of daily living. Adults might have various work activities that they do, but children need to play. Play is essential for a number of important outcomes, including attaining neurodevelopmental milestones of motor function, cognitive function, social functioning, problem solving, communication, and the list goes on. Importantly, play is also fun. Incorporating play into mobility activities in the ICU can change the experience that the child has in the unit to a much more positive one, potentially reducing the impact of some of the adverse psychological consequences of PICU stay. So there are a number of different types of play activities that one can incorporate in our mobility activities: construction, block play, active play, dancing, playing with a balloon or a ball, bringing in music play, creative play, doing drawings, for example. What about water activities, hydrotherapy? Again, this is something that I've been doing for many years, but one way of really bringing water play safely into a unit is bringing a small paddling pool into the unit, which we've done now for a number of patients. It's warm, soapy water. It's comfortable for the child. They have so much more freedom of movement in the water, and they can really play while getting all the benefits of mobilization in a safe, contained environment, even while fully ventilated. If you look at the literature, there's a wealth of barriers that people report. I do believe that these barriers are largely based in fear of the unknown. And I think that most of them can be overcome. And largely, they can be overcome through good interprofessional communication. In terms of equipment, we've looked at that. I don't think you need fancy equipment to achieve your mobility goals, and certainly we've never had that equipment. We do have guidelines or practice recommendations that one can follow, which also highlight which patients are appropriate. How do you tackle medical complexity? In terms of insufficient resources, I was interested in the slide that Debbie showed about the costs of delirium care. I think that it's much more cost-effective to prevent the complications of immobility instead of implementing mobility practice. So it's resource effective to implement mobility in ICU. As far as safety concerns go, we've repeatedly shown that there really are no major safety concerns if you work appropriately. And in terms of aspects like oversedation and pain, well, we have the Liberation Bundle in place. If you get everything right, I think we start losing these barriers, we start breaking them down. But my suggestion is, wherever you are in the world, if you are looking to start an early mobilization process within your unit, is be pragmatic. Start where you are, use what you have, and do what you can. In this regard, something is always better than nothing. And one of the resources that all of us should have is family presence and engagement in the PICU. We know from the PARC PICU studies that family engagement and presence is positively associated with out-of-bed mobilization. So family engagement really requires a collaborative process that helps parents to really understand the rationale and the benefits and the process of early mobilization. And if they fully understand it, they can start becoming actively involved. And that active involvement also allows some activities to be sustained beyond the relatively brief mobilization session by whichever health professional is providing it. Parents really are best placed to determine their child's level of comfort and pain, and they are best able to communicate with their child and understand their child's verbal and nonverbal communication. So by having the parent there as an interpreter, if you will, it really will improve the child's level of cooperation and motivation. But moving away from family with the sole purpose of improving mobility outcomes, we need to remember that wherever you are in the world, a child that's admitted to the PICU remains a child with children's needs. Being admitted to a PICU is terrifying. You're in a foreign environment with strange noises, strange people, strange equipment, with things being done to you that you cannot understand unless there's a trusted adult there who is able to explain it to you and provide comfort. And we know that there are huge psychological consequences of PICU stay on the child. And I do believe that these impact on a number of physical outcomes as well. I also don't think that we don't always appreciate the pressure that having a child in the PICU has on the parent, not being aware of how your child is, not understanding what is being done to your child, and not being able to take care of the child yourself must have huge impact on the parent. And I know as a parent myself, if you didn't let me help my child while they were in an ICU, I would be absolutely devastated and wouldn't be able to cope. So we know that for a child in PICU, family is an important source of comfort, a source of familiarity at a time when the child really needs it the most. It helps the child to feel reassured, safe, and orientated. And in that regard, it may, although this is not proven, it may reduce problems, for example, of delirium. Just having the parent present, though, is also not enough. We need to engage in a family-centered care approach, which is really a partnership approach to healthcare decision-making, It allows us to provide care that's respectful of and responsive to individual preferences, beliefs, needs, and values. And it has been suggested that by engaging in family-centered care and improving communication and involvement of the family within this care, we can ultimately improve health outcomes. I'm sorry the slide got corrupted along the way, but family-centered care looks different in different sociogeographic regions. So it's been reported that in some developed countries, family-centered care really more involves care that's led by the parents in dialogue with the medical staff, whereas where I work in Africa, family-centered care is more about the active participation in physical, psychological, and social care of the child. But regardless of where you are, I think that parental engagement and participation in the care of the critically ill child is always associated with reduced parental anxiety and child anxiety and higher satisfaction levels. It's also been shown to facilitate parent-child bonding, it empowers parents, and it provides hope. Again, I'm sorry, but there was a text box that disappeared along the way. If we're looking at the effect on outcomes of parental participation, we do not have pediatric empirical evidence. Adult studies have shown positive clinical outcomes related to family participation in terms of reduced delirium and reduced cardiovascular complications. Now, we don't have the evidence in children, and I really don't think we can assign children to a control group here. It would not be ethical in any way. But I think we can all intuitively appreciate the countless benefits that allowing and encouraging parental participation could have on the child outcomes and certainly on parental satisfaction levels. You saw the child that I showed earlier looking terrified in the ICU shortly after receiving a tracheostomy for Guillain-Barré syndrome. This is the same child, having been mobilized into a standing position and allowing the parent to be involved in the care. We don't need empirical evidence necessarily to see the obvious, that early mobilization and family engagement have huge benefits for both the child and the parent. Thank you.
Thank you. It's my honor and pleasure to be presenting to you today. My name is Karen Chung. I'm a pediatric intensivist from Hamilton, Ontario, McMaster in Canada. You've heard from my esteemed colleagues a really great summary of how to implement the different aspects of the bundle. And I'm going to talk about how to optimize adoption and sustainability of the A2F bundle in your units. I'm going to start with my take-home message. For us to optimize the adoption of ICU Liberation is to think about it not so much only as a bundle or practice guidelines, but to think about it as standard of practice and expected practice for your institutions. It requires us to think about ICU Liberation as decreasing patient harm and improving patient safety. It requires us to think about ICU Liberation as improving the quality of care. What is quality of care? Quality of care requires us to think about how we're doing something, our process of care, the delivery of that care to our patient. And improving that care requires us to think about the change that is required to do something better. My apologies for some of the formatting issues that were lost in translation. But in healthcare, the quality of care is defined by these 6 components. How effective that intervention is it safe, is it patient-centered, is it efficient, is it timely, and is it equitable? And so patient quality and safety is big business for our hospitals and institutions because it is linked to patient outcomes, but it's also linked to patient costs, and it's linked to patient satisfaction. And so our hospitals, our institutions invest in patient safety officers and quality improvement personnel. They promote patient safety champions, and they require us to take regular patient safety training. Our hospitals are required to transparently report on key quality and safety indicators, known as key performance indicators. And these are linked to resources resource utilization, and remuneration. And so these key performance indicators are set by the hospital, and they're typically similar amongst different hospitals. And they include bed occupancy rates, wait times, length of stays, and the clinical outcomes that are linked to these resources, such as mortality rate and adverse event rates. Also included are hospital-acquired infections, and you can see these are the top 5 hospital-acquired infections that we're required to pay attention to, and we're all aware of these and familiar with these because they affect us in the unit. Ventilator-associated pneumonias, central line-associated bloodstream infections, catheter-associated urinary tract infections. And you can see why these are important key performance indicators because these 5 major infections cost the U.S. hospitals $9.8 billion in 2012. Our PICUs and our ICUs also have key performance indicators. These may be influenced by our institution, but they're also often influenced by regional, or in our case in Ontario, provincial requirements. That allows us to benchmark against our other colleagues and ICUs in our region. As an example, in our ICU, you can see our key performance indicators are similar. There are these hospital-acquired infections such as VAPs and central lines and bloodstream infections, and the unwanted adverse events such as unplanned extubation, medication errors, and resource utilization, such as the length of stay. There may be external drivers to your key performance indicators. Some of your institutions may be members of Solutions for Patient Safety. Solutions for Patient Safety, or SPS, is a collaborative network whose mission is to eliminate serious adverse events and hospital-acquired complications across all children's hospitals. You're required to subscribe or have a membership to SPS, and there are at least 144 hospitals across North America now working together, and this provides a mechanism by which we can share methodology to decrease harm in our hospitals. You can see on the SPS mandates, the list of HACs, hospital-acquired complications, are similar to the key performance indicators that I showed to you before. The important point here is that having key performance indicators work. Having standards that are driven by leadership and hospital administration actually are major drivers for knowledge translation and practice standards in our institutions. As a result of which, you can see that these hospital-acquired conditions have decreased, lives are saved, and dollars are saved. I'm going to point your attention to the underlying rate of these unplanned extubations, pressure injuries, and adverse events in children's hospitals. These are the key performance indicators that our units are required to monitor. They are important, but look at the event rates. They're low. They're likely to be lower because we're not intubating patients as often. We're not putting as many invasive lines as we used to. Contrast these to the key PICU-acquired conditions that are the target for ICU Liberation. You see the rates here, and then my colleagues have summarized these consequences and their incidence, their prevalence very, very nicely. I will say that 100% of our PICU patients will experience at least one of these morbidities during their ICU stay. This is the magnitude of the conditions that we are talking about. Why are PICU conditions then not a part of key performance indicators? You heard presented already that they lead to poor patient outcomes. They lead to increased resource utilization. They lead to increased costs. They lead to consequences, not just in the ICU, but out of the ICU. You've heard presented by Dr. Morrow the post-intensive care syndrome. These have direct consequences and costs to the patient that are sustained well long after they leave the ICU and also to the medical system. We have a solution. We have an evidence-based bundle that is targeted specifically to decrease these acquired harms. The ICU Liberation Bundle, I say, is the poster child for quality improvement because it fulfills every single one of the criteria that defines quality of care. You've heard presented that it is efficacious, it is effective, it is safe, it decreases harm, it is patient-centered, it is family-centered, it is efficient, It is timely, early for everybody, and it is equitable. So why hasn't it made it to a key performance indicators? In fact, we have evidence from as early as 2012 that it should be. This systematic review showed that the routine assessment of pain and the routine assessment of sedation level should be included as key performance indicators for ICUs. Another study published in 2009 showed similar findings. What they showed that the lack of routine pain assessments and the lack of sedation level assessments was associated with increased mortality and increased length of stay. You've heard very nicely presented guidelines, pediatric guidelines. These have been published now for over several years. Are pediatric guidelines enough to change practice? You heard nicely summarized by the PICU study that despite having several iterations of practice guidelines now published, both in adults and pediatrics, the uptake and the adoption of the Liberation Bundle is challenging. That is true not only in pediatrics, it is also true in adults. In this international study, they showed that less than 50% of the 135 units involved had guidelines. Practice guidelines are not enough to deliver the care to the patient. And you can see the rates here summarized that the actual delivery of these components to the patient was much, much lower than even the rate of having a guideline in their unit. You heard Dr. Zimmerman talk about waiting and the waste of waiting, and this oft-quoted evidence that it takes at least 17 years for clinical practice to translate evidence to translate into clinical practice. What's concerning is that the evidence suggests that it may take even longer to de-adopt unnecessary practices. That is concerning to me because the Liberation Bundle is all about de-adopting practices that have been steeped in tradition. We know that ICU Liberation Bundle sustainability is challenging. The COVID-19 pandemic has shown this to us with the resurgence in immobility, excessive sedation, and restrictive family presence, policies mandated by institutional leadership with the best of intentions, just bearing in mind what leadership can do to the undoing of practices for which there's evidence. So, with that in mind, my task now is to show you why ICU Liberation is the poster child for quality improvement. We now, fortunately, have evidence on implementation of ICU Liberation. We know the factors that influence adoption into practice. Dr. Bettis said that it's difficult, implementation is difficult. I would say now we have accumulating evidence how to make what is difficult easier. We now know what the barriers and facilitators are. And what is interesting is that the barriers and facilitators are actually common amongst institutions. They're common amongst both pediatric and adult ICUs. So this is the evidence that we've now gathered, not just from our own studies, but our own implementation studies, but others, and I hope to summarize these for you in the next few slides. The first barrier is our unit culture and practice. You've heard this say that the unit readiness for change or reluctance to change is what often influences practice. What the common barriers are, in fact, is us, clinicians, doctors, how we practice. We were at a focus group the other day, and that was one of the recurring themes of how clinicians are inconsistent in applying the bundle. We're reluctant to change. So how can we create clinician buy-in? First and foremost is we need to view rehabilitation and the ICU Liberation Bundle not as research, but standard of practice. How do we do that? Make sure you embed this as an expected requirement in your unit. We include pain scoring, level of consciousness assessment, delirium scoring, mobility risk scoring, all those things that are required in your Liberation Bundle as vital signs. These are not optional, they're mandatory. Not just asking your clinicians or your nurses and your allied health to do these vital signs for you. Provide them with the value. You ask your nurses to tell you what the blood pressure when you're treating a patient with septic shock. You ask them what your saturation levels are when you're treating a patient with ARDS. These vital signs should be reported on every single patient, every single day, at every single opportunity, and also a nursing expectation on their transfer of accountability. Ensure value. Use these to generate a discussion and a team collaboration in the patient goals and plans every single day. Again, we target blood pressure when we're treating septic shock. We should be targeting outcomes of pain assessments, level of consciousness assessments, delirium scoring, etc. The next barrier, a common barrier you've heard before, nurses, RTs, not often physios, I would say, are really scared to mobilize patients. They're scared to decrease sedation. They're scared to allow awakening. We need to educate not just the clinicians at the bedside, but also the patients and families. As you've heard before, they are your strongest ally, but they also have reservations because they're spending a lot of time with your bedside nurse. Educate both the nurses, clinicians, and families that ICU Liberation is about decreasing harm because it's about improving patient safety. Educate them about what we talked before. We spend a lot of time trying to minimize these key performance indicators, CLABSI, unplanned extubation. We should be paying equal attention to decreasing these common harms in terms of iatrogenic withdrawal, delirium, sleep disruption, and parental stress. You've heard the data summarized for you that the ICU Liberation Bundle and early mobilization is safe. There's systematic review evidence for it. But we now have evidence from our implementation study that it decreases toxic exposure. Implementing an analogous sedation approach decreases exposure days. Implementing a benzodiazepine sparing approach not only decreases benzodiazepine exposure, but in our bi-center study, we showed that it actually decreases all classes of sedatives. I found that quite interesting and impressive. Clinicians are afraid about awakening and mobilizing children, including the infants and toddlers. We now have implementation evidence. This is a time series analysis, and you can see for yourself. Wakening up a patient, decreasing the sedation, does not increase pain or discomfort. In fact, it improves it, and awareness, and your ability to assess their pain. And it also does not increase adverse events. It does not increase unplanned extubation or falls. Concerns about nursing workload. We're asking our nurses to do these. Are they really complex assessments, delirium assessments, pain assessments? We're asking them to get them out of bed. Nurses are afraid about increased workload from the ICU Liberation Bundle. We now have implementation science evidence that it does not. Nursing workload is not increased. If anything, I would say, well, actually, not if anything. I have it up there on the slide. There's evidence that shows that it improves interprofessional team collaboration because you're working together to do it. You heard about cost savings. Cost savings because you're decreasing morbidity. There's actually evidence out there that it improves or saves costs from healthcare provider injuries. When you're getting these patients up, you're not actually causing more harm to the healthcare provider either. How do we ensure delivery and sustainability? How do we ensure that we deliver the ICU Liberation Bundle to every single patient every single day? Again, this is evidence-informed from implementation study. The first is, don't just take somebody's guideline, tailor that to your unit. Each unit is different. Your patient population may be a little bit different. Tailor it to your unit's needs by including input from your team and input from your families. You've heard that family engagement is key to every single aspect of that bundle. if you engage your team and your families into tailoring that guideline for your, or those guidelines for your unit, it encourages team ownership. Make sure you embed order sets. Embed the practice into your order sets and make sure that your order sets are educational. Education, you've heard about education in every single aspect of the bundle. My comment about education is as follows. Mandate it. Don't just make it one training day. Don't just make it, although very excellent, a training session at the SCCM. Make sure you embed a mechanism to deliver that education regularly in your unit, because you've heard the turnover of not just nursing staff, but clinicians, physicians, trainees is high in your unit. Develop a mechanism that encourages regular education. So we embed it in our syllabus, we mandate it, we require that our clinicians are recertified regularly on ICU Liberation. Make sure your education is point in time. You've heard about that in terms of high functioning or pre-arrest patients. I would say look at the opportunity as clinicians to educate on ICU Liberation on every single patient as you're rounding on them every day. Ensure that you have accessible educational resources and decision support, whether that be through low-cost technology or through a handheld or through electronic health records. We used a low-cost, low-tech glass door to transparently display patient goals for those vital signs. We found that we've adopted EPIC into our healthcare system, and what we found that while there are documentation standards within EPIC, it is not a replacement for verbal team communication. And so we use a glass door to encourage daily goals checklists, and what we found that it actually increased compliance and increased the rate that every single aspect of those bundles, that bundle was discussed at rounds. Make sure that it's not just at a patient level, but at a unit level. So we have daily team huddles when we talk about patients who are on pad alert, patients who are at risk of delirium, at risk of immobility. Have process observations, meaning involve your unit staff in monitoring for compliance. There are easy ways of doing that. Have liberation champions. You've heard what a long way that having a champion goes. We call them safety champions because we're improving patient safety and decreasing patient harm. Celebrate successes. Photo ops go a long way. Parents love it. In fact, it empowers them. They want to celebrate the success of their child. These anecdotes we learned in our focus group the other day is one of the most powerful motivators to get buy-in. If a nurse has experienced somebody with delirium, if a nurse has experienced being able to mobilize somebody, that is a very, very powerful mechanism for knowledge translation. Last but not least, I started with leadership, and I'm going to end with leadership because I believe this extrinsic factor, meaning extrinsic to the unit, your hospital leadership institution, is one of the most powerful and important drivers of knowledge translation and resource utilization. So lobby for change in your unit through leadership, but understand what you're asking them for. It may be different for your different units, but I think there are some general things that we should be asking our leadership for that you heard already presented. Number one, we need to make sure we have a documentation standard. Ask for the Liberation Toolkit, the minimum data set, to be embedded and an expectation as a documentation standard in your unit. Know who your patient safety officer is, because they have access to this data. They know how to generate compliance. These are run charts. These run charts are being generated for every single one of those key performance indicators that I showed you earlier on. Lobby to have resources dedicated for them to pull this for your unit, because your unit staff respond to data. They love seeing improvements. It drives and motivates them. Compliance is not alone. Alone is not important. Performance is what is important. If you collect the minimum data set on liberation, you will be able to generate these compliance data and these outcomes data for the proportion of patients who have delirium, for example, your length of stay, and so on. Use this to lobby these liberation outcomes as key performance indicators for your institution. We talked about external drivers. I think we should be lobbying to solutions for patient safety to include delirium as a hospital-acquired condition, because it is not unique to the pediatric ICU. There are other children in your pediatric institutions, for example, oncology patients at very, very high risk of delirium. I choose delirium because it's tangible, there's a distinct data point, there's a diagnostic criteria, and it ties everything together. Solution for delirium is the whole ICU Liberation Bundle. And with that, I hope I've convinced you that ICU Liberation is the poster child for quality improvement. I also believe that ICU Liberation is a solution for quality of life improvement and improved functional outcome in our patients. And thank you very much for your attention.
I want to thank Karen for that absolutely fantastic presentation. Hopefully she's convinced you that we owe it to our patients to implement the data that we know is going to improve their outcomes. We are out of time, so I'm just going to take 2 minutes to kind of put this all together for you. We're going to run through a case scenario twice. We're going to compare and contrast the traditional approach to our mechanically ventilated children with the ICU Liberation approach. So we're going to start with a 6-year-old previously healthy boy. He doesn't exist, but I've named him Alex. Alex was admitted with influenza virus pneumonitis and acute respiratory failure with superimposed bacterial pneumonia. He is quite ill upon transfer to the ICU. Within 2 hours, he requires intubation for hypoxemia. The unit gets him settled, and he's now on moderate ventilator settings. His PEEP is 8, his FiO2 is 55%, and his hemodynamics are stable. Now here's where 2 roads diverge in a wood. Traditional approach. The initial sedation plan, Alex is started on fentanyl and midazolam infusions. He awakens from sedation and appears agitated. What should be done? Well, he gets bolus doses of fentanyl and midazolam, and the infusion rates of both drips are escalated. This cycle repeats itself multiple times over the first 24 hours. By day 2, his fentanyl, this is a previously healthy kid, so he's not kind of opioid exposed or habituated. This previously healthy child is on a fentanyl infusion of 3 mics per kilo per hour and a midazolam infusion of 0.3 milligrams. His bedside nurse notes that he is, quote, impossible to sedate. And she, in all distress, says, I'm afraid he will auto-extubate. Oh no, this is a big trigger for our unit practice. He is then placed in restraints and his drips are increased. The mom, when the child wakes up, goes over to his bedside and the nurse says, no, I just got him quiet. I just got him still. Don't touch him. Don't stimulate him. He has some hypotension that is associated with the sedation, and he requires several fluid boluses over the next several days. His AA gradient increases for about 3 or 4 days, and then it plateaus. At this point, one would be inclined to wean him, but despite the high-dose sedatives, he has these periods of emergence agitation, which require actually intermittent doses of paralytic. He's now edematous and bed-bound 4 days into his ICU course. So by day 7, we were able to start some diuresis. We're able to wean his sedation a little by addressing some of his delirium. His chest x-ray is better, his PIP is improved, and we begin to wean the ventilator. That's day 7. However, whenever we decrease the sedation, the patient's agitation, which had been pharmacologically masked with the high-dose sedatives, emerges. We then note that he has hyperactive delirium and opiate withdrawal. So it takes 3 more days to kind of organize his sedatives and wean his ventilator, and he's now ready for an extubation trial. We'll contrast this with the PICU Liberation approach. Alex is a 6-year-old previously healthy boy who comes in with influenza virus pneumonitis and a superimposed bacterial pneumonia and pretty severe hypoxemic respiratory failure. He's intubated, same ventilator settings about 2 hours later. The initial approach is different than the traditional approach. He's prescribed acetaminophen and ibuprofen around the clock, TNT, it's dynamite, in addition to morphine every 2 to 3 hours. The goal here is optimal pain control and minimal sedation. He is given a RASS goal. Our RASS goal for Alex is 0, and the nurse has the ability to titrate to that RASS goal. So if the RASS goal is 0 and Alex's sedation level is -1 or -2, he needs less sedation. If his RASS level is +1 or +2, then he needs something to address that agitation. He, just like the first Alex, awakens several times over that day. He's given several extra loading doses of morphine and he calms. But the cycle repeats itself 2 times over the next several hours, where he wakes up, requires more morphine, wakes up, requires more morphine. Does he have opiate tolerance? Because I've heard that. Oh, wow, this kid's really tolerant, right? He clearly just needs higher dose opiates. He doesn't have opiate tolerance. He's never seen an opiate until today. So it's highly unlikely this is opiate tolerance. What this is likely is just that he needs extra loading doses of morphine, but no increase in the standing dose. He still appears anxious, and he deserves something for his anxiety, right? It's not his fault he's 6 with respiratory failure. So a dexmedetomidine drip is initiated and titrated to effect. He's earned his sedative. It wasn't given to him as a party favor. Welcome to my ICU. Here's your endotracheal tube, and here's your sedative. He's shown that he requires sedation. We've also reassured ourselves that his pain is very well managed before we added on that sedative. He's able to sleep for a few hours, but then he awakens and he is able to communicate pain when his nurse suctions him. So a plan is made for preemptive morphine to be given about 10 minutes prior to any scheduled suctioning. Despite moderate ventilator settings, he's awake, he's reasonably cooperative, he's mobilized. My ICU is not so fancy, so we didn't have enough staffing. It was a Sunday, we didn't walk him, but he's mobilized in his bed. It's turned into a chair. He's given a handheld game to play. He's interactive with his parents and his staff, and he sleeps for 5 hours that night. His mom kind of rubs his feet, and he had watched a football game with his dad earlier in the day. Twice daily delirium screening occurs when his delirium score begins to rise, so we don't wait till his kind of CAP-D score reaches that threshold of 9. The medical team looks for what they can do, what might be modifiable that could be contributing to his delirium. They review his medication list, they discontinue some unnecessary anticholinergic medication that had been started 2 days earlier. They also remove his Foley catheter. His subsequent delirium scores improve. Despite this excellent care, his AA gradient does increase over the first 3 days. His pneumonia is blossoming. So his RASS target, which had been 0, is now changed to -1. We now want him drowsy to facilitate patient ventilator synchrony. Several boluses of dexmedetomidine are used, and an increase in the infusion rate achieves target sedation. By day 4, his chest X-ray and his peak pressures improve. His sedation target is raised again. His target is now 0. We want him less sedated. His medications are weaned accordingly, and his ventilator begins to wean. As he has been spontaneously breathing and he's been exercising for most of his ICU stay, he has not experienced significant deconditioning. He has not experienced severe agitated hyperactive delirium, and he quickly weans and is successfully extubated on day 6 of invasive mechanical ventilation. So obviously, this is an overly simplistic case. I did that to make a point, right? My point is that, as Albert Einstein so eloquently stated, intellectuals solve problems, geniuses prevent them. By using the quality bundled approach to care that we have shown you is effective, safe, and sustainable, we can avoid the problems, the iatrogenic problems that we cause in the course of providing critical care. This is a ripe opportunity for quality improvement. Not only does it improve the quality of care we provide to our patients, it's also good for their parents and it's good for our hospital staff. Our ICUs have gone from looking a lot like this, where you kind of were default intubated, deeply sedated while critically ill, and then you kind of looked dazed and confused on the back end, to ICUs that look like this, where children are awake and alert while being critically ill and interactive with their staff and their family members. To conclude this session, we can shift our historical approach to sedating children to an analgesia-based approach. There's a large body of evidence that shows it's safe and effective, and by preventing delirium, mobilizing patients, and involving families, we can likely improve outcomes in critically ill children. But there is so much work to be done. To quote the philosopher William James, as a community, we pediatric intensivists, compared to what we ought to be, we are half awake. working together, I believe we can change that. We're officially out of time, but whoever wants to stay before lunch happens, I'd just like to invite the panelists up here so you guys can ask any questions that you have. I thank you very much for your attention.